You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 382 of the podcast. And in this one, I got on Professor David Veale and Dr. Rob Willson. Both David and Rob have been on the podcast before. David is a consultant psychiatrist specialising in cognitive behavioural therapy, and Rob is a cognitive behavioural therapist. So in this episode, we discuss what is health anxiety, the episodic nature of health anxiety, the similarities and differences between health anxiety and OCD, death anxiety, the second edition of their book, Overcoming Health Anxiety, some of the worries and safety behaviours within health anxiety, compassion-focused therapy, exposure-response prevention therapy, and much more. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. Thank you to all of our patrons for supporting our work. This podcast episode is available as a video recording on our Patreon. To sign up to our Patreon and to check out the other benefits you'll receive as a patron, please see the link in the show notes. So thank you to David and Rob for their time. I deeply appreciate it. And of course, thank you to you guys for listening as always. It means a lot. And without further ado, here they are. Welcome back to the show, David and Rob.
Thank you.
Thank you very much for having us back.
Yeah, it's good to have you here. So, obviously off air, we were just discussing how long it's been since I last interviewed you both, obviously separate, but you guys do a lot together with BDD and the foundation there. But anything you wanted to update us on about your lives, your work, research, anything like that?
I'm rather modest, so no, I don't think so. I mean, we're going to talk today about health anxiety, aren't we?
Mm-hmm. Yes.
And we've got a self-help book on overcoming health anxiety, and it's always been an interest, and often quite, as we know, it's related to OCD. It's a related condition, and sometimes it overlaps and can be a bit tricky to separate out. But it's often, I think, we find quite a chronic condition often, where it comes and goes and different types of problems. One time of your life you're more preoccupied by AIDS or something. Another time of your life you're more preoccupied by some multiple sclerosis, and then it's into something to do with heart disease or something. It moves around, I think.
Yeah, good point. And Rob, from you, anything you want to share?
Well, still at it. Still mainly working as a jobbing CBT therapist. I'm very, very glad to be doing so. Really,
excellent.
Excellent. But I would echo what David just said. One of the interesting differences between OCD and health anxiety is how episodic it can be.
Yeah.
And I think that does make it a challenge for some people, because it can seem to then kind of go away or sort of take care of itself, or sometimes the right form of reassurance and the right test will temporarily put things to bed, even for a few years.
Yeah.
And then it comes back, sometimes in a different form with a different focus. But it is one of the challenges with this particular problem.
Yeah, that's interesting. Whereas OCD may be more consistent, even if the severity might change a bit.
Yeah.
So I'm glad you guys have both addressed that, because that was one of my questions going to be fairly early on. To me, health anxiety feels very much like OCD, and you've obviously said it's different. And how would you define that it is different to OCD?
Well, I think health anxiety is much more about a preoccupation with a fear or belief that you have a severe illness, which is, life-threatening or progressive in some way, altering in some way. And some people go down the route of being absolutely totally convinced that they have that particular disorder. Most people, it's more about a fear and a worry. And that leads obviously to all the checking and vigilance for looking out for symptoms and signs, and going on the internet and you're going to repeated reassurance from doctors and family members, and constantly checking your body and avoiding certain physical, symptoms and so on. It's sometimes it's driven more by the fear of death. Others are more driven by just the fear that you'll be suffering and disabled for a very long time.
Okay. Yeah.
Or perhaps that you won't be able to look after your family in the way that you usually, or not be able to discharge a responsibility because you're ill, and therefore letting people down because you've missed something important.
Yeah.
Really good point. And that's what I was going to ask you as well. Like, almost, you mentioned death just then. It's kind of like, I was curious about how anxiety, how much is it like an existential worry of death, of at the core fear that ultimately we're going to die, and that is incredibly terrifying for anyone to comprehend.
Well, for some people, health anxiety, that is the core fear. My colleague Rachel Menzies, who we've also written about death anxiety with, will argue that there is a revolving door. In other words, that there are people with anxiety who present in charge often, let's say, of separation anxiety, and then they might get panic attacks when they're older, and then perhaps they might get more OCD, and then develop into more health anxiety. That it keeps going around different types of anxiety problems because no one's dealing with that fear of death. And that's what still needs to be tackled. So we're very keen on death.
Okay.
Death anxiety.
Yeah. Good.
I think the other theme that's getting more attention, similarly, that's sort of across different presentations of anxiety in a person's lifetime, is this theme of intolerance of uncertainty and related ambiguity. And I think that when we're seeking to help people with health anxiety, that's often a particular focus that being able to live with and tolerate a bit of doubt, even when it's about something as important as one's health.
Yeah, so it's the not knowing if you've got cancer is worse than actually knowing it, that you have cancer. Yeah.
Yeah. That sort of anticipatory. Okay.
Really important concept within health anxiety, the not knowing.
Yeah. Of course. And then when you do get the test from do the test with the doctor, and the doctor says you're clear, then do you believe the doctor? Did the doctor mix test results? Did they, blah, blah, blah. Yeah.
Well, like OCD, it is a doubting disorder, and you may reassure you briefly, but then another doubt pops into your head, and or some other condition or symptom or whatever. So it never stops.
Yeah,
it raises another interesting point that some people don't understand about health anxiety, which is that there is sort of broadly the kind of care seeking version, and then there's the kind of care avoidant version, in which the kind of the archetype is of someone who's a old-fashioned hypochondriac pitching up to the GP regularly for lots of reassurance and tests. But there are plenty of individuals with health anxiety who are very careful to try and avoid contact with their doctors for fear they may be given some bad news, or indeed fear that the look on the doctor's face might again trigger some doubt about whether there's some illness that they've got that the doctor isn't really willing to tell them about for fear of them worrying too much, or fear of them getting really bent out of shape about it.
Interesting. So the care avoidant, do those people still have the I may have cancer worry, but I just don't want to know? Or is it, I know I kind of have health anxiety and I don't want to be triggered? Or
I think both of those.
Yeah, exactly.
Yeah.
But we mentioned the word there, hypochondriasis, and it's a rather negative association, of course. That's why we tend to use health anxiety. Officially, it's still referred to as hypochondriacal disorder in the ICD-11, but it has a lot of negative associations, doesn't it? So that's why, the problem is you've changed names, of course. It doesn't really change the condition. The Americans now call it illness anxiety disorder. We like to call it health anxiety. But, the key thing is the processes. In other words, like Rob mentioned, the intolerance of uncertainty and the way that you might catastrophically misappraise certain bodily sensations, the way that you're constantly monitoring certain sensations, you're very self-focused, the way that you're constantly ruminating about these things, the way you're checking, the way you're avoiding. And these are the most important processes to identify. We don't get too worried about what the label is.
Yeah, it's a good point. And as you share those processes there, if I didn't know this topic was health anxiety, I could easily think you were talking about OCD. I know we have to draw the lines somewhere. How often though?
I was going to say it is sometimes a bit artificial. The terminology like OCD or health anxiety is helpful because it's a description at a top level. And it's helpful for people to be able to communicate and for people to be able to do studies on and things like that. Yeah. But it is, another 50 years' time, other people will cut the cake and its diagnostic cake in a slightly different way. Mm. And it will be, all different. So it is just how things are divided at the moment.
Yeah. Yeah. Good.
Products of committees, not products of nature.
Yeah. True. Yeah. Yeah. Very true. Yeah. So, OCD and health anxiety. How often? What's the comorbidity between the two?
I can't give you the statistics off the top.
No, that's okay.
I mean, if it's true comorbidity, then it will be other types of OCD. It's somebody who's very preoccupied by being responsible for harm occurring, or someone who's having unintrusive, unacceptable thoughts, or something like that. Yes, there's sometimes a bit of an overlap, like fears of contamination and the idea that you'll get very severely ill from it and so on. But it's more about, I think, shared processes that are important to identify. Sometimes, as you say, people have both problems. I think that the bigger comorbidity or additional problem is more of depression, because, if you've got chronic health anxiety, people then get, like in OCD, more severely depressed and so on. And it just grinds you down, this constant interference in your life.
Yeah.
Other people getting pissed off with you, constantly seeking reassurance and so on.
Maybe, David, generalized anxiety disorder?
Yeah, possibly as well. But, this is what we were coming back to before, that people often go in and out of these different types of problems. Yeah.
Right.
And
I just had an intrusive thought.
What
of a patient who, 20 years ago was so convinced that she had cancer, even though she didn't have cancer, and everyone's trying to highlight that she didn't. So convinced, almost a delusional belief, and as a result depressed, that she had to end her life because she did not want to make suffering for her family when she died from cancer. So it can get very severe in that delusional belief as such, and nothing can stop you. It was very sad, and because she didn't have cancer or anything like that. She had a severe mental disorder.
Yeah, good illustration. And I don't think I'd ask any other guests this question, but because of your background and interest in BDD, what's the again, you don't have to know the percentage, but like the overlap between BDD and health anxiety? Because BDD is externally focused from what I understand, and then health anxiety is more internal. What have I got? What's going on for me? So the two sides are the same coin, if that makes sense. So is there any, or they completely, you don't see it much?
Occasionally, again, they overlap a little bit. But often, no, it's not so common, I think, that in terms of that comorbidity. It often overlaps with other types of OCD type problems, particularly olfactory reference disorder, where you believe you're emitting a smell, a bad odor. But, as you know now, all these things a bit like a big Venn diagram, and there are some people overlap a little bit, and other times they go in and out of them, and so on.
Yeah. Okay.
I think it's the case that BDD at one point was a sub-diagnosis of hypochondriasis.
Yes, it all comes under the old ICD-10, that it was all part and parcel the same thing.
Yeah. So obviously at one point there's a thought they were quite strongly associated.
Yeah.
Well, I guess the brain.
David says we do sometimes see people that have had both, and there is that kind of bodily preoccupation dimension to both problems.
Yes.
And of course, checking and self-focused attention and things that relate to that, as well as the tolerance of uncertainty. But it's a bit like comorbidity with OCD. You don't see it that often. Individuals with health anxiety.
Yeah, that's interesting. And it's good we've jumped straight into this and we've got into the meat. But one of the early questions I had was just hearing an update, because this book, I've got it right in front of me, Overcoming Health Anxiety, is the second edition. So what's the book about for those that have never come across it? And for those that have read the first edition, what's their incentive to go pick up the new edition?
Makes us an extra 7p, I think. Rob, can you, there is some new stuff. I think, it was needed updating because I think there are some better conceptualizations of the problem and really targeting. We've got more examples of different types of health anxiety and really some good practical things you can do to try to help yourself. So it's much more of a step-by-step self-help rather than, I think the first one was a little bit more, too much just education about it as such.
Okay.
No, I think that's right. And that we've also updated to include the slightly more work on compassion-focused ideas and the evolutionary side of our psychology, because that, is I think much more common what we're trying to present in these books is the kind of experience that you might get if you saw an experienced CBT therapist for these kinds of problems. So we're trying to add things like a more sophisticated version of how you'd apply exposure, and bring in the kind of concepts like compassion that we would probably use more in our day-to-day clinical work now. Things that have changed perhaps in the last 10 or 15 years.
Yeah, brilliant. And I actually want to ask you guys in a minute about compassion-focused therapy. But just before that, we've obviously dipped in now in terms of explaining health anxiety and some of the, I'm going to call it obsessions and compulsions, just, for my audience and for my understanding to make it simpler. But what are some of the obsessions / worries, and what are some of the compulsions or safety behaviors people might do around health anxiety?
You want to go with that one, Rob?
Sure. No, absolutely. So David's already talked a bit about some of the main obsessions. So these are often, it's a fear that one has an illness or they're going to get an illness, but it does tend to cluster around sort of very dreadful illnesses, things like cancer and heart disease, but also things like motor neurone disease, where people fear things like becoming locked in. So their disease is often that people fear for understandable reasons, because they're quite the idea of slowly dying and withering away from certain kinds of cancer or being in endless pain towards the end of your life. These are quite frightening ideas. And often they have this dimension where one of the important things is the idea that you might miss something important. And for a lot of the fear in people's minds is that there's always going to be this scenario that one day they'll maybe follow our advice, please don't keep checking and please don't keep going to the doctor. But the fear might be that one day they'll have a consultation with a GP who says, why didn't you come to me sooner? This is terrible. You've ignored these symptoms, and we could have done something if you come sooner. But now, because of your lack of responsibility and negligence, you're really in trouble. So that's where that kind of sense of responsibility can kick in.
And of course, something we also highlight is that it's not just about physical illnesses. There are also people who fear having a severe mental illness. They'll go mad, get schizophrenia, dementia or something. Or sometimes the fear that they have OCD when they haven't got OCD.
Yeah.
So it can cover everything.
Yeah. And one of the big things that's changed, of course, in our modern times in terms of compulsions is Google.
Yeah.
And there's some researchers think that it's Google is not to blame, but that process of being able to quickly and easily access a lot of health-related information and do a lot of checking and reassurance seeking on the internet, that some people believe that has increased the prevalence of health anxiety. And certainly consulting Dr. Google is something that a lot of people do these days. But if you, rather than when I first started out this work, people were reaching for their medical textbook.
Or they could get to see their GP. But
or they get to see their GP.
True.
Or, of course, the private sector is a great, fantastic source of revenue for people from health anxiety, because, of course, they go and get more and more investigations done just in case something, or maybe we could check this and check that. And I think also alternative health practitioners see a lot of people with health anxiety and can provide that narrative about what the explanation for their symptoms, about their the chakras being misaligned or whatever it is. So, there are all sorts of different manifestations.
Yes. So seeking medical information is a big, or kind of medical type information is a big compulsion in health anxiety. Obviously, bodily checking and poking and prodding and scanning and checking one's breasts or for lumps and bumps, looking very closely at one's legs to see if there's any fasciculations and nerve twitches and things. So looking and feeling for trying to gather more information can be a strong compulsion. Also, people tune into their bodies and try and feel for bodily changes from the inside. And particularly if you've got fears of things like dementia, or you're scanning and checking your memory all the time, or fears of having some kind of brain tumor or something, when you're trying to work out, does my mind feel the same as it did this time last week or this time last year? There's lots of internal scanning and focusing on sensations as well, which gives you lots of signal. And the danger is then that you're more likely to misinterpret that signal as being evidence that you've got a particular illness.
Yeah, good point. And obviously, the more you check, the more anxious you get. The more anxious you get, your memory's probably not working as well as it could. You're going to feel a bit more funny and peculiar, which you might label as some kind of illness or Alzheimer's, or And of course, the more you check, it prevents you from tolerating doubts.
Right.
And this is one of the key things we're saying in health anxiety, that you don't tolerate the doubt. So it's another great example of where, your solutions are the problem, and it sort of maintains it.
Yeah. And the same problem is true of people who seek not only reassurance from medical sites and things, but also, of course, from friends, family members, partners, and the experience of family members or partners saying, they just don't listen. I keep telling them there's nothing wrong with them, but they just don't listen. You can see the frustration that this causes in relationships as well, where people are repeatedly asking describing a symptom, asking someone to have a look at it, and the family member or partner provides the reassurance, but it just doesn't hold, it doesn't take.
And the same thing, of course, occurs with self-reassurance, the constant chatter in your head of what you're telling yourself and reminding yourself about what you've looked up or what you found or what the doctor said, and so on. So you can't escape.
No.
So the people who do really well are those that we help to start to really get very enthusiastic almost about tolerating uncertainty and seeing things as an opportunity to really practice living with more doubt. So when the urge to seek reassurance arises, or the urge to check arises, they're then sort of pivoting towards leaning into that doubt and uncertainty, and becoming stronger and stronger and stronger with the practice in tolerating it, and allowing then the catastrophic thoughts and fears to subside.
Yeah.
And there's plenty, of course, of avoidance behavior in terms of things that you don't want to trigger off your fears and so on. So, if, let's say, the person has got a fear of some chronic neurological problem, they're going to avoid hospices or places where individuals are are living where they've got these chronic diseases, or they might even be avoiding a hospice charity shop, or anything to do with, of course, the death things, whether it's writing your will or discussing your funeral wishes, or there's plenty of avoidance.
People spend sometimes, don't they, take big journeys to avoid going past graveyards.
Yeah.
And avoiding medical dramas and documentaries and anything that's going to activate those fears.
Wow. Yeah. Like how kind of much it can take over your life, because there's ambulances everywhere, there's sirens everywhere, there's occasionally accidents, and obviously on TV, ER and all that. ER's still a show, or Holby City, or whatever it is, they're everywhere, right?
But actually, the dream of someone with health anxiety is to have your own personal ambulance that you can, or your own personal doctor, and this, that, and the other.
That's true. Doctor on call. So thanks for that. That was really, really good. So I'm going to go on to therapies now, but I think let's start with compassion focused therapy, because you mentioned it. Since I became a therapist, compassion focused therapy is I've done a lot of CPD in that area, just because I find it, I think, just important for humans generally to develop that inner compassionate voice, but especially for people with OCD. How do you see CFT helping health anxiety?
Well, one of the key. Sorry, David. Do you want to
go?
But I think one of the important things is to be able to understand that people tend to think in health anxiety that the way they should handle it is they've got to stop thinking bad things about their health. They've got to stop having these thoughts, which again has a similar problem in OCD. But the brilliant thing about compassion focused therapy is it really underlines this idea that your brain's just trying to help. It's trying to keep you safe. So warring with those thoughts, or warring with the part of your brain which is actually it's functioning well, it's on your side, so can be really helpful just in terms of changing one's relationship with those kinds of doubts and intrusive thoughts. And therefore, rather than being cross with your brain or cross with yourself for having them, you can, again, it just facilitates that idea of, okay, let's step back, let's just let them take care of themselves and settle down. They're happening for good reasons. But the other thing I think that's really helpful from compassion focused therapy is the focus on learning to just down-regulate your stress and to reduce arousal, even if it's through, say, soothing with breathing or accessing a compassionate image. Having some other mechanism to deal with the stress and the anxiety of the condition, rather than seeking reassurance or avoiding to provide that relief. So it does provide some very useful additional tools.
Nice.
Yes. So obviously, the evidence is still that the cognitive behaviour therapy is the main treatment of choice for health anxiety, and following the right protocol. What we're saying here is that things like compassion focused therapy, we think, can be a helpful module or something to add, especially in those with more difficult and more chronic problems.
Yeah, absolutely. Yeah, it fits so perfectly with CBT. Arguably CFT, I found, can integrate with many therapies. And probably makes them, I don't want to say more effective because I don't have the research for that, but I predict
it's difficult to prove that, but
exactly, but maybe more palatable. At least when I work with my clients, it just makes things a bit, I don't want to say nicer, but I will. Okay, so we talked about
sometimes for people that have been through the mill before, of going through ERP for the problem, it can add a sort of fresh take. Still help you to kind of focus on, ultimately you've got to be courageous, and that's also part of CFT and understanding that, to relieve your suffering, you're going to need to do your ERP. So that actually ERP in this sense is an act of compassion. But I think for some individuals, it provides another platform to have a slightly refreshed approach, but still, as David says, really still at the core of it has the ERP, but it still isn't the same old thing exactly that I've had before.
Yeah, it's just a different twist to it, right? The same as when you integrate acceptance commitment therapy with ERP. It's the same thing with a different angle, which might work for some people better than just traditional ERP. the same mechanics are there. With CFT, and you mentioned earlier in the interview about you didn't necessarily link it to CFT, I don't think, but I think that's what you meant, was the evolutionary angle. And that's what CFT talk about, right? That we all have tricky brains. And as you just said, Rob, it's our brain really trying to help us. Whether it's OCD or health anxiety, it's not out to get us. It's out to save us. It's just doing too good of a job of it. And it's now annoying.
And it doesn't think through to the consequences.
Yeah.
Difficult being human. If you're a crocodile, you wouldn't get health anxiety.
True. Well, that we know. Maybe. I know what you mean. Yeah.
Get me to the doctor and make it snappy.
Yeah. Yeah, good. Yeah. It's the things we hate about being human. I don't know where I'm going with this, but if we weren't human, we wouldn't have it, but we wouldn't have all the other great stuff that comes along with being a human too.
Absolutely.
Imagination does.
We wouldn't be on this podcast.
No, there you go. Yeah. There's no crocodile OCD stories.
Again, that we know of.
Yeah, there could be telepathy or whatever it is. So let me look at my questions. Yeah, so let's go on to ERP then. ERP being the main treatment for health anxiety, or most research?
The first step is to have a really good understanding of exactly what's maintaining, keeping the problem going, and developing an alternative understanding of what the problem is. The old thing, theory A, theory B. Theory A is that I'm going to be dying from a severe neurological disease and that I better watch out and do all these things to monitor that, as opposed to theory B being it's a worry problem, it's an anxiety problem, and that all the things I do to treat it as a neurological disease actually keeps the problem going. It maintains it. It strengthens the preoccupation and the distress. Mm-hmm. So you have to really treat this as a worry problem, an anxiety disorder. And that means testing out your fears, facing up to your fears, and acting according to your values and things which are important in your life, not according to how you feel, living life to the full, despite your fears.
Yeah.
And along the way, some of that, it's going to evolve if you realize you become unnecessarily or overly afraid of certain, even some people find even certain words become, potently anxiety provoking, or certain images, certain places, certain people, certain situations. So the part of dialing your worry down is going to be to face up to certain situations, cutting back on the reassurances and the checking and the fact finding and so on. And maybe some practice in considering, at least being able to hold in mind, there are more than one explanation for a certain bodily or mental sensation, to practice not necessarily leaping to the conclusion of the worst case scenario, but also learning to live and tolerate more uncertainty about it.
Yeah.
And as David says, this is all done in light of understanding the problem differently.
Mm-hmm. And obviously emphasizing there's no benefit from getting to the bottom of it all. Lots of people still want to get to the bottom of things. And unfortunately, we now know that, look, there's often a significant component of heritability, which you can't do anything about. Then stuff happens, your parents mess you up, and you get teased, you get bullied, all sorts of crap happens in your life. But unfortunately, you have to deal with things now. Now, having said that, occasionally there are trauma memories and things that it is important to emotionally process. Yeah. But in general, trying to get to the bottom of it all is unhelpful and will send you down more rabbit holes.
And I think the important word there is where you feel like you're having to try to get to the bottom of it. It's rarely needs drilling down to. Sometimes people will definitely have experiences which have been, I can think of one or two people who have been unfortunate enough to see a family member die in front of them.
Yeah.
Or have witnessed accidents or something where it doesn't take a rocket scientist to realize that might have elevated your sense of vulnerability more and your awareness of your own mortality at that.
So you might have one session understanding the development of the problem, but really you don't need to spend, sometimes you see people in years trying to get to the bottom of it all. It just encourages them to ruminate.
Yeah. Shouldn't be detective work. It should be, understanding work and maybe casting a more understanding light on things. And maybe sometimes there's some emotional processing that can help things along the way.
Yeah. Yeah, good points. So to illustrate ERP for health anxiety a bit, is there like, doesn't have to be a real client, or it could be something that's anonymized, but like that would bring what ERP, obviously it's going to massively vary depending on the type of thing they're worried about, but what are we exposing to, and then how are we holding
Well, it
back
depends again, like in OCD, it depends what you're avoiding, or it depends what it is that you're particularly fearful of. So, obviously, if it's around death, then there are plenty of things you can do exposure to, because usually such individuals might have more magical thinking that perhaps if they write their will, then it might bring it on, or they might be particularly avoidant of writing their funeral wishes or discussing it with their family. They might well be avoiding visiting cemeteries or funeral parlors and things like that. I mean, so there's a whole section on what you can do about death fears. But it depends, really on what it is that you're really avoiding. It may be things in the media to do with your health and other things that trigger you. So plenty of things that you can do behavioral experiments and exposure to. It depends on your particular problem.
So some of those, and David couldn't be more right to say that the starting point needs to be what's currently anxiety provoking or are you avoiding, rather than therapists feeling they've got to wheel out a bunch of tricks, tried and tested tricks for any obsessional problem, including health anxiety, because that's a bad starting point. The starting point needs to be, for any problem solving, understanding the problem that you're solving well and building from there. So it would be very idiosyncratic.
I mean, that for health anxiety, it's often things like, exercise, because, I don't want to get my heart racing.
Right. I was about to use the example of some women I've worked with who resist hugging their children for fear that that might activate a sensation in their breast and that increase their doubt that maybe that reveals a tenderness or a lump or something. So, it can be something as you really need to know that individual's, the way their mind's working about their health anxiety, to understand the function of not holding your kids close. But if you understand that it's potentially a trigger, or even sexual activity can be a trigger for a fear that I might find someone might touch something, I might feel something that feels different or wrong, then that triggers the doubts. So it's really you've got to understand what it is that's going to trigger off images, bodily sensations, and doubts and so on for that particular individual.
Yeah, really, yeah, absolutely, really good points. And I think something you said, Rob, earlier, you didn't say excited, but it was a word like that about getting people excited for tolerating uncertainty, or it was something along those lines. So to both of you, like, how do we do that as therapists? Because a lot of my
enthusiastic,
okay,
and approach these problems with gusto.
Okay,
that is definitely true, but I think, but the best thing we can do is sometimes ask people to run. It's part of the experiment, is that to test out what it's like, spending some time in more avoidant or more checking or reassurance seeking phase compared to what it's like if you're trying your best at least to embrace uncertainty and to try out that it's a golden opportunity to change your relationship with these doubts and uncertainties. And so when people see it for themselves through experiments, that's oftentimes the greatest buy-in. And I've known people that have become borderline evangelical about, the benefits of making friends with uncertainty, and how, we really should be telling more people about this and why it's on buses, because they've been through it and they've really found it terribly helpful. So it's discovering that it works oftentimes. So David's dead right that we need to, particularly health anxiety, a bit like BDD has been at times, where people it's had a bad rep, and then there has been historically at least a bit of a kind of sense that some problems are kind of groan worthy, and they're a bit of a pain, and you wish people would just stop worrying about these things. But David and I both know that actually working with problems like OCD, health anxiety, and BDD can be incredibly rewarding, and the opportunity to make a difference in someone's lives, and you know this too, Stuart, is that that is really invigorating and really exciting. So coming at a problem, particularly like health anxiety, where maybe there's been a lot of people starting to get a bit annoyed with you about your reassurance seeking, the GP seems a bit fed up, the family definitely getting fed up, and being the person who's really, really curious about how does this work, really interested in let's see what we can do to make this different. I think that certainly promotes that hopefully that journey of really arriving at a place where your relationship with thoughts and doubts and so on is very different.
Really, really good points.
You talked there about response prevention. Well, again, it needs to be individualized. But for most people with health anxiety, it's all the resisting the urges to check, isn't it? In terms of whether it's on the internet or going to your GP or checking your body, all these sorts of things, and trying to find an alternative that is and helps you to tolerate that doubt.
Yeah, good points. So how can families support their loved ones with health anxiety?
Well, it's about trying to help them develop more emotional support for reassurance rather than just talking about the content of the illness and condition. It's not about, no, you haven't got such and such, and, you know, we told you before, and you know that it can't be because you've had your tests done or whatever. That's the reassurance route, as opposed to emotional support, which is, I understand, darling, this is tough, this is difficult, let's just stick with it, let's stick to the plan, and give you a big hug.
Nice.
Yeah. And again, showing real interest in what the person's homework is, not kind of looking over the shoulder necessarily, but having a family member who is checking in, asking how it's going. You know, did you manage to do your exposure and response prevention today? I've noticed that you've been asking fewer questions, or it seems like you're spending less time. I notice you're not staring into space so much as you used to, where I could tell that you were viewing the last conversation you had with the GP or something. And, you know, just that person who's, again, is a support on the journey with great curiosity and interest on what's going on, and avoiding irritation and frustration and criticism, which tends to, if you want to slow someone's treatment down, reassure them a lot, and then get really annoyed with them that they're not accepting the reassurance. That'll really put the brakes on things.
And it's a bit like, you know, OCD, isn't it? In the sense that people want to be terribly rational, but rationality doesn't cut it.
No.
Yeah. You gonna say something there, Rob?
Well, you know, there's the classic thing: if you didn't arrive at the problem through reason, you're unlikely to solve the problem through reason, and as we've already described, that this is a primitive process of our brain trying to keep us safe, and it's the brain. Your amygdala doesn't speak English. It needs warmth. It needs courage. It needs action to change.
Yeah. Show it.
That's not to say that you don't need good rationality and wisdom and understanding what the problem is, but that is not at the time when you're highly anxious.
Right.
It's the context that's important.
Yeah, good point. So words of hope for anyone listening with health anxiety.
Definitely. All these conditions of OCD and related disorders, there is always hope and a different angle to take. It's not something you have to live with until you die. Because you are going to die, and that's to the full.
Yeah, true.
I think something else that's always worth. I'm sure the people that are listen to your podcast will be very aware of this. That it takes for a lot of people, it takes more than one go at therapy to crack it. And particularly for health anxiety, because it has this interesting dimension where it will sometimes just sort of deactivate. And both client and therapists are left there wondering, okay, I'm not quite sure what we're supposed to be doing now, because it seems to have slightly gone away. And David sometimes talked about this idea of putting people into the deep freeze and then defrosting them when they're ready to, the problem's back online and we've got something more meaty to get our teeth into. But for, any OCD is very common that people have to have more than one go. And certainly with health anxiety, it's common that people have to have more than one attempt. And there's things to be learned from each experience, and some things that maybe worked and some things that didn't work so well. And that sometimes with more than one pass, you just kind of find that you kind of get to a point where you think, okay, right, I am really starting. I realise that little sneaky check that I always kept doing just to be on the safe side, or that little bit of Googling I always kept doing just to kind of, make sure I was covering both bases. There are things, safety behaviours that people eventually then drop. There are exposures or ways of relating to uncertainty or difficult thoughts that people find that they can start to face and lean into. And it's a problem that really, people make enormous change in. But it doesn't always happen the first time around.
And if you do have severe health anxiety, particularly chronic progressive, then it's certainly worth considering talking to your doctor or psychiatrist about medication, because like OCD, it can certainly help to take the edge off the anxiety and can help to improve your quality of life as well.
Yeah, good points. So lastly, anything else you wish you could have said or shared on this topic?
I just want to go back to this theme, I think, of living life to the full rather than trying to sort out your future life or death or your current health, because, you work out the amount of time you spend in trying to solve a non-existent problem. Yeah. This is the time to be living life to the full and living with that uncertainty and not knowing and tolerating the doubts.
It raises a really quite important way of understanding health anxiety, which is the definition is that it's a disorder of preoccupation, which means it's a disorder of spending too much time thinking and worrying about certain aspects of life, which is, we all should be somewhat concerned about our health. But the idea that sometimes people find that is to spend more time investing in other activities, to think of life as there is only so much time you've got in any given day. There's only so many minutes in any given hour, and that each time you manage to steal the time that you might have spent checking or researching or reassurance seeking into some other valued aspects of your life, it means that you're living life now, trying to live to the full, but you'll also be, in a slightly more indirect way, weakening and undermining some of the lifeblood of your health anxiety, and that will support that recovery.
Yeah, good point. Spending less time ruminating, less time doing the other compulsions. Yeah.
One of these days, I'm going to have a national campaign on ruminating.
Yeah.
It is dangerous to live in your head.
Bad for your health.
Yes, whether it's OCD, health anxiety, whatever, living in your head and ruminating, very dangerous.
Yeah.
And it's a bit like smoking, ruminating damages your health.
In quality of life.
Yeah.
Maybe that's the next NHS campaign.
Yes. I'd like big posters.
Nice. Let's do it. Cool. Look, thank you so much for coming on, sharing your expertise, and obviously sharing your book. And I'll put a link in the show notes to anyone that wants to go check that out.
Brilliant.
No, thanks for your thanks for having us on, and thanks for your interest in this, what is sometimes a kind of slightly neglected disorder. So really, really, really appreciate you kind of shining a light on it.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. And if you want to find out more about NoCD, head to go.treatmyocd.com/theOCD stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.